Division of Radiation Oncology, Department of Oncology of National Taiwan University Hospital. I have no conflict of interest to disclose.
可以吗？不行，我点一下哈。好，再点一下。另外一边。
Okay. To summarize this case, synchronous tongue cancer and esophageal cancer, for clinically T2 and 1 tongue cancer, squamous cell carcinoma alone, the optimal treatment, the treatment of choice is curative surgery, and depending on pathological risk factors, adjuvant RT or CCRT is based on pathology risk factors. And for isolated esophageal cancer, moderately differentiated squamous cell carcinoma, upper to middle third, the optimal treatment is still a matter of debate. Neoadjuvant CCRT followed by response-free evaluation and surgery, or upfront surgery followed by adjuvant treatment if needed, are both acceptable treatment options. However, treating synchronous oral cavity and esophageal cancers did raise lots of problems. First, should the treatment intensity remain the same as we treated two diseases separately? And second, what is the optimal treatment sequence? And how should the treatment sequence be integrated? And third, there's also surgical issues regarding surgical technique and complication. And fourth, what is the optimal chemotherapy regimen? And last but not least, treating synchronous cancers brings a lot of challenge for radiation therapy. For example, the doses and fractions for head and neck cancer and esophageal cancers are different. For head and neck cancers, doses ranges from 60 to 70 gray in 30 to 35 fractions are commonly used. And for esophageal cancer, the neoadjuvant CCRT dose ranges from 40 to 50 gray in 20 to 25 fractions, and definitive dose from 50 to 66 gray in 25 to 33 fractions. And in addition, treating synchronous cancers, we have to use very large radiation fields starting from skull base to celiac lymphatics. So one isocenter is sometimes feasible, but rotation of collimators might be needed. And if we use two separate isocenters, problems of field junction and setup uncertainty should be carefully addressed. And the choices of beam directions for head and neck cancer and esophageal cancers are different. Also, larger field results in increased dosing homogeneity and hotspot area. So how should we come up with a treatment strategy for this case of synchronous cancer? One rationale is that for medically fit patients with good performance status seeking curative aggressive treatment, one rationale is to combine the treatment as much as possible in order to shorten overall treatment time. And from a radiation oncology perspective, radiation is a potent inducer of inflammation, and irradiated tumors or cells release large amounts of cytokine, chemokine, angiogenesis factors, and also show bystander effect and metastatic capability. So in addition, decision for adjuvant treatment of tongue cancer is highly dependent on surgical pathology data. So two possible treatment options are provided for this patient. One is to operate the tongue cancer first, and depending on surgical pathology results, adjuvant RT or CCRT and neoadjuvant CCRT for esophageal cancers should be integrated together, and followed by response evaluation for esophageal cancer and curative surgery if feasible. And option number two is to perform upfront surgery for tongue cancer and esophageal cancer at the same time, and adjuvant treatment if needed, and could be integrated together. And from National Taiwan University Hospital Cancer Registry during the year 2000 and 2011 and 2014, 3 patients with synchronous oral cavity and esophageal cancer were identified. And patient number 1 is a 69-year-old gentleman with history of hypertension, gout, hyperlipidemia, and presents with weight loss from 71 to 61 kilograms in 10 months. And the first primary site is tongue cancer, moderately differentiated squamous cell carcinoma. Images showed a 2 centimeter right dorsal tongue tumor, and there is also a 2 centimeter enlarged lymphadenopathy at right level 2 to 3 junction. The clinical stage was T2N1 disease. And the second primary site is esophageal cancer, squamous cell carcinoma, middle to lower third, 28 centimeter, and 35 to 38 centimeter below incisor. And images showed middle lower esophagus with invading muscle layer, and there are at least 3 para-esophageal lymph nodes. Clinical stage was T2 and TN0. Our treatment strategy for this patient is to start with curative surgery for tongue, and then we integrate adjuvant CCRT for tongue and adjuvant CCRT for esophagus together, followed by restaging for esophageal cancer and curative surgery for esophagus. So the patient received partial gastrectomy and right type 2 R&D. And pathology showed a T1 tongue cancer. The lymph node was 2 positive out of 34 dissected with closed margin of 0.2 centimeter and positive extracapsular extension. And the patient then underwent adjuvant CCRT for tongue and neoadjuvant CCRT for esophagus, concurrently with weekly cisplatin at 30 mg per square meter. And we performed radiotherapy with 2 separate isocenters. And one, we treat the head neck region with 7-gauge angle MRT technique. At NTUH, we use a SIB technique, simultaneously integrated boost radiotherapy technique, to 3 dose levels for head neck cancer in 66, 60, and 54 gray in 30 fractions. And for esophageal cancer, we use a 4-gauge angle MRT technique and treat it to 40 gray in 20 fractions for neoadjuvant dose. Notice that we limit the beam angle of the radiation to decrease the lung dose. And this is the ISO dose curve for the treatment planning. The primary tongue and neck tumor bed was treated to 66 gray, and right side upper to middle neck, and also left upper neck to 60 gray, and right lower neck, and also left lower to middle neck, and also bilateral retrostyloid process space to 54 gray. And the esophageal field include upper mediastinum and all the way down to the cilia lymphatics. And restaging showed a complete metabolic response of esophageal cancer, and which is proved by a negative pathology. And US showed a 4 paraesophageal lymph nodes. And the patient then underwent a curative surgery for esophagus with transthoracic subtotal esophagectomy and total laparoscopic gastric tube reconstruction. And the pathology is amazing, which is a pathologic complete response. The patient is actually doing very well right now. He is still alive and disease-free for more than 4 years with fair swallowing function and good performance status. And there is no need for feeding tube or episodes of stricture or aspiration pneumonia. The patient number 2 is a 60-year-old gentleman with type 2 DN presenting progressive dysphagia for 4 months. And the first site is a left heart palate cancer, well-differentiated squamous cell carcinoma. Image showed a left posterior heart palatal cancer with extension to posterior maxillary floor. The clinical stage was T4A and 0. And the second primary site is esophageal cancer, squamous cell carcinoma, middle to lower third, and 29 to 38 centimeter below incisor, and with adventitia invasion. And there is also at least 4 paraesophageal lymph nodes detected with the US. And PET also revealed a gastrohepatic ligament lymph node. So the clinical stage for esophagus is T3 and 2 and 0. However, the patient refused operation and received induction chemotherapy TPF with Taxotere, cisplatin, 5FU for 1 cycle, followed by definitive CCRT for both head, neck, and esophageal cancer, concurrently with cisplatin at 30 mg per square meter. And this is, we treat this patient with 2 separate isocenters, one at head and neck region with 7-gauge angle MRT technique to 3 dose levels with SIB technique to 70 gray, 60 gray, and 54 gray. And for esophageal lesion, 4 gantry angle IMRT SIB technique to doses of 55 gray and 45 gray in 25 fractions. The hard palatal tumor and suspicious neck lymph nodes were treated to 70 gray in 33 fractions, and also left upper middle neck and also right upper neck to 60 gray, and left lower neck and right middle to lower neck to 54 gray. And the primary esophageal tumor and enlarged lymph node was treated to 55 gray in 25 fractions, with prophylactic dose to upper mediastinum and down to cilia lymphatics to 55 gray. And the patient remaining completion for left heart palatal cancer 8 months after treatment. However, there is also local regional progression and distal metastasis for esophageal lesions. The PET revealed a more enlarged and more intense uptake at esophageal tumor and also gastrohepatic ligament lymph node. And there are also new metastases at celiac nodes, SMA nodes, parietic aortopepal nodes, and also C-spine metastasis. And salvage chemotherapy with PFU, CFU were continued for 7 months. And the patient is still alive with recurrent left heart palatal cancer and progression of esophageal tumor, abdominal lymph node, and also there is new left axillary lymph node metastasis. And the last patient we have is a 58-year-old gentleman presented with painful ulcerative nodule over left tongue for 2 months and slurred speech with weight loss from 69 to 59 kilograms in 2 months. And synchronous tongue cancer at left dorsal tongue, clinically T2, and also cervical esophagus, squamous cell carcinoma, clinical T2-3 was diagnosed. There is also a 2.8 centimeter necrotic lymph node at right level 4. And the patient started with a curative surgery for tongue. There is a partial glossectomy, the left side type 2 MRND and right side SOHMD. Pathology showed a T1 disease with bilateral extensive lymph node metastasis, LBI positive, and close margin with 0.2 centimeter and positive extracancer extension. So adjuvant CCRT for tongue and definitive CCRT for cervical esophageal cancer were then integrated together. And he received weekly paclitaxel and cisplatin as a concurrent chemotherapy regimen. We performed radiotherapy with 1 IO center and 7 gantry angle IMRT SIB technique. The head and neck region, and tongue tumor bed and neck tumor bed, and also cervical esophageal lesion was treated to 66 gray and in 33 fractions. And we prophylactically irradiated the upper neck, bilateral upper neck, and bilateral lower neck, and also upper mediastinum to dose of 60 gray. And the patient was remaining complete remission 3 months after the treatment. However, another 1 year later, there was no local regional recurrence for both head, neck, and esophageal cancer. However, distal metastasis did develop. And the patient was alive, but now with progression of disease and received that supportive care only. In conclusion, although we cannot make any statistically significant conclusion with this limited number of case series, long-term disease control is possible with aggressive multi-modality treatment in certain patients. So there are unsettled issues. For example, should the same staging system be applied to the synchronous cancers? And in addition, more precise patient selection is needed to define certain groups of patients for aggressive curative treatment. And finally, the optimal treatment for synchronous cancers will also keep evolving. And maybe we need a multi-disciplinary and institutional collaboration to a better solution for this kind of patient. Thank you for your attention.